let's get this rodeo started. We are going to kick off our first session, Sharpening Your Spurs with the Basics of Lung Cancer. To guide us through these basics and all the things that we need to know, I am delighted to introduce friends and colleagues, Kim Faught, Thoracic Coordinator with Texas Health, Fort Worth. Kim absolutely built their lung program from the ground up and works diligently to improve early detection and the care for patients she's privileged to serve. Also joined by Shandy Grisham. Shandy is a certified advanced oncology nurse practitioner with over 25 years of incredible experience. Shandy serves as the lead advanced practice provider at the Center for Cancer and Blood Disorders. You can read Kim and Shandy's bios along with all of our incredible speakers on the app. So I encourage you to go ahead and check out those bios when you can. Please join me in giving a warm welcome to Kim and Shandy. Let's get our spurs sharpened.
Thank you so much, Christy. That was a great welcome and introduction into what's going to be an amazing weekend, and we are so delighted to be here to educate and just be here for the community on lung cancer. It's something very near and dear to my heart. As you can see, I have been in it for many years, but I have family members I've taken care of from beginning to end, and so God put me in this path before I knew I was supposed to be in the path, and this is just one great weekend that we get to celebrate with all those survivors and family and friends. Next slide. So she asked us to come today to talk about Lung Cancer 101. Lung cancer is in the community, whether you're in Dallas, Fort Worth, or anywhere in the United States, anywhere in the world. When somebody hears lung cancer, it's scary. Cancer alone. Cancer is where cells that aren't supposed to be dividing and growing form a spot or a tumor. That is all the word cancer means. It sounds extremely scary, but it is our body that is supposed to have cells dividing to normal cells that turn into a spot or a tissue, and that is what the word cancer means. We have two cancers, or we have cancer that's malignant and benign. Those are medical terms that many people hear. Benign means it is a non-cancerous. Malignant means it's cancer, whether it's a lung cancer or any other type of cancer. Next slide. This is just a picture showing what our normal cells should do. Our normal cells should divide and turn into a normal, healthy tissue. The bottom slide shows those normal cells that have a mutation for multiple reasons we'll talk about, but they mutate. Instead of dividing into normal cells, they divide rapidly and they form that spot. Next slide. Some of the changes that cause this genetic mutation, there's a lot of research going on out there, but there's multiple things that can cause a mutation. Genetic mutations, DNA mutations from damaging things from the environment, smoking, inherited genes. There's a lot of things that we can change with lung cancer, but there's a lot of things that we don't have control of. Next screen. Some of those genetic changes, hereditary, UV radiation, we do know that can cause changes in our genetic DNA. Smoking, chemical exposure, and viruses can also change that DNA. Next slide. So what is lung cancer and what types of lung cancer? When you hear the term lung cancer, the first question I get from patients is, what kind is it? We have two types in the community that is talked about very often. There's non-small cell lung cancer, and there's small cell lung cancer. I often hear, which is better? Which is the most aggressive? Non-small cell is the most common, and small cell is the most aggressive. Next slide. This is just a picture of the lungs. When we talk about cancer, a lot of patients don't realize our lungs have 3 lobes on the right, upper, middle, lower. The middle lobe accounts for about 8 to 10% of your lung function. And then on the left, we have the upper and lower. Also within the lungs, we have the bronchioles, which is through the center
of the chest. And then we also have the peripheral, which is closer to the outside of the chest. Next slide. The term carcinoma means cancer or malignant. Carcinoma can be added onto the end of any type of diagnosis. The non-small cell is divided into 3 types. We'll talk about the first 2 first. Adenocarcinoma. Any cancer patients out here, this is the most common word that you hear. It gets pronounced multiple ways, adeno, but adenocarcinoma is the most common. The other type is squamous cell carcinoma, and what distinguishes these 2 types is where they originate. The adenocarcinoma comes from mucin cells or fluid. Squamous cell carcinoma comes from the lining of like the lungs, the bladder, intestines. Both of these cancer types can be found anywhere in the body. They are not specific to lung, but they are the most common type of the non-small cell lung cancer. Next slide. So let's distinguish between the 2, non-small cell and small cell. They are very different. The question I hear when we do a new diagnosis, because I give new cancer diagnosis daily, that's part of my role as a thoracic coordinator. What stage is it? What does treatment look like? The community knows stage 1, 2, 3, and 4. On a small cell lung cancer, it is not staged like a non-small cell. So when talking to a patient about small cell, there is limited stage disease and advanced. The difference is treatment options. You can see on this slide, I'm not going to go over all of those, but limited stage for small cell cancer is very different than advanced stage. And with that, you have surgery, you have chemoradiation, and when it is advanced or extensive stage, that means it has spread outside of the lung. That small cell cancer is the most aggressive between the 2. And non-small cell, not to get confused that it's not aggressive, but it's slower growing than the small cell. Small cell tends to respond quicker to treatment. So when I give a cancer diagnosis and they say, what's treatment look like? You tend to see a quicker response with small cell. The adenocarcinoma also responds, but it's a little slower to respond. And it's a little slower to see symptom improvement if it's advanced and you do have symptoms. Next slide. This is just an overview slide about where we can find cancers. There are 3 types of the non-small cell, and we really haven't touched much on the large cell carcinoma. It's the 3rd group from the non-small cell. It is not common like the adenocarcinoma and squamous cell carcinoma. Locations of cancer, this is pretty specific. It can be multiple areas, but the adenocarcinoma you typically see not in the bronchioles because, again, it is with the mucin. It can be further out in the lung. The squamous cell, we do see that more in the lung, and this is the type that is associated more with smoking. However, adenocarcinoma can be smokers, but also is more common in non-smokers and women. And the large cell carcinoma, it is the least common, 5 to 10%, and it is typically in the peripheral lung. So I hear patients ask, it's in the peripheral lung, it's outside of the lung, right? In our terminology, peripheral still means inside the lung, but it's toward the outside of the inside of the lung. It's still in the lung, but it's toward the edge, and that's what this picture can show us. Next slide. This is just another version of showing us where those cancers can be found. It's kind of repetitive from the last slide, but it just gives a better picture of the adenocarcinoma squamous cell carcinoma, and then the large cell. Next slide. We're going to go a little more detail into each of the cancers. And again, if you have questions, keep those or write those down or put them in the comments for after. But we're going to get not too technical because I want to keep this to a language that we all can understand. In the medical field, it's easy to talk in the medical world. But I want to keep this very, very down to community discussion. Non-small cell carcinoma, the most common is called adenocarcinoma, as mentioned. It's 35 to 40% of all lung cancers. We see this in the lung, but again, you can see it in the breast, colon, pretty much anywhere in the body, but when it comes to the lung, it's the most common cell type. Again, it's usually closer to the outside of the lung, but don't be confused. It can be found anywhere in the lung. It's just more common to find it peripherally, otherwise known inside the lung on the outside edge. And maybe on your pathology report, if any of y'all get the my chart or you read the pathology that sounds like a foreign language, you might see a TTF1 positive, and that is very specific to adenocarcinoma. Next slide. This is just a picture of a CT. So this probably looks very foreign to y'all. When I talk to patients about CTs, can y'all still hear me? No? Yes? Okay, sorry about that. When I talk to patients about CTs, I'm a picture person, see it to believe it. I'm from Missouri originally. So this picture is a picture of a lung. The black areas, that's the shape of the lung. On your left that you see is your right, and then it's opposite of what our brains think just by the view. And I explain it to patients like this. You are laying on the table, and I slice you up like a loaf of bread. I pull that slice out, and I lay it flat. And that's what this picture is. It's showing, this one has the tumor that you can see. It's kind of peripheral, meaning it's on the outer edge of the inner lung on the left. So this is the left lung where that spot that's dark, that should not be there. All the little crow's feet and all the little spots, that's just bronchioles and airways that normally, if you were sitting upright, would look like an airway, but we've cut it in half. So all of that is normal. In the center is the heart, but that big white blob that you see or tumor, that is the actual lung cancer. Next slide. So the second most common non-small cell is squamous cell. This accounts for 25 to 30% of all lung cancer cases. Again, as mentioned before, it is more associated with the patient that has a smoking history. Doesn't have to have a smoking history, but it's more common. It's typically located more in the bronchioles, so closer to those airways of our lungs versus out on the peripheral. It can be found outside of that, but it is more common to find it on the airways. And that pathology report that you see would say TTF1 negative. That is one of the stains that they can do to differentiate between adenocarcinoma and squamous cell. Next slide. You can see of this picture again, that's that loaf of bread sliced up with one slice pulled out. This is a bronchiole that has the tumor in the bronchiole, so it is not toward the edge of the lung, but it's actually in an airway and has grown into that airway. Next slide. The least most uncommon, rare, you don't hear about this much in the community, is large cell carcinoma. It's usually toward the outside of the lung. Rarely do you see this in the inner part of the lung or bronchioles. It's very common for it normally to be on the outside. And with this pathology, it's very similar to the other. It's atypical, meaning it's not normal, but it does not have the staining characteristics of adeno or squamous. Next slide. So it looks very different, you can see, than the others. The others were a spot or a tumor. This one is literally right on the surface of the lungs. Those little white spots that you see, that's actually the ribs, and that is the tumor that's right on the very, very edge of that lung. Next slide. So I'm going to hand it over to Shandy for staging, and we will be open to questions at the end, but she's going to take it over from here. Thank you.
Can you hear me? Oh, good. I have much older eyes than Kim, so I have to stand up front because I can't see over there. I'm sorry I have a thick accent. I'm not Texan by birth. I came here, been here about 25 years, but I'm from Louisiana originally, so I'm sorry if it's very thick. I apologize. I try to talk slower and try to mute down my accent, but that's really hard to do. But so when we are looking at your treatment, the things that we as providers need to know are these things. Doesn't matter what your cancer is, but of course we're going to focus on lung cancer. So the first T stands for the tumor itself, and that goes based upon the size of the tumor, from something that's 0 up to about 7 centimeters when we're talking about lung cancers. That's a big tumor, by the way. So if you look at your finger, your thumbnail, that's usually about 1 centimeter. So if you think about 7 of those, that's a pretty big tumor in your lung. The N stands for lymph nodes or nodes. So we all have lymph nodes all over our body, and any kind of cancer can spread to those lymph nodes from its original site. So in lung, you have all kinds of lymph nodes in your chest. When you're sick, you can feel, sometimes you feel a little knot up under your chin, and that's when you have an infection in your mouth or a respiratory infection. Those are lymph nodes that you can feel, but we have those everywhere. So with lung cancer, we're looking to see if you have any of the lymph nodes in your chest that have been involved with the cancer. You get a pretty good idea when we're doing the CAT scans. A lot of times you can see those lymph nodes. But after you're getting a little deep here, but after surgery, they will look to see if some of those lymph nodes are positive in certain cancers. But just know the N stands for lymph node involvement. So when we're looking at lung cancer, you think about ipsilateral. Ipsilateral means on the same side. So if you have, like Kim was showing here toward the end, you have a tumor that's in your bronchial tube and you have a lymph node that's on the same side, that's different than if it's on the other side of your lung. And so that plays a big part in when you talk about treatment and what you can do as far as treatment options. And of course, the M stands for metastasis, and that's when we know that it's spread from the place of origin. So when you have cancer that is spread or metastatic disease, that's stage 4, when we talk about your standard 1, 2, 3, and 4 stages on non-small cell lung cancer. But once cancer spreads, we can't fix it forever. We can't make it go away. But we've come a long way with our treatments, and so we have much better outcomes than what we did years ago. All right, next slide. So this is super busy, but if you look, we're going to go on to the next slide. If you'll just go ahead and advance, the next one's easier to look at. So it's a lot of graph, a lot of information, but it breaks down. All the T's are based upon the size. You have T1, T2, T3, T4, and then the M is for the metastatic. So you go from, if you march them up by the T and the M and the N's, you can figure out what your stage is. And yes, we have a lot of, A's and B's. It's a little bit more complex, but it gives you an idea, especially if you get your pathology report and you're looking at that, you're like, oh, okay, I can understand what that means. If you'll go on to the next slide. So all the different treatment modalities. We've come a long way. I've been around doing this a long, long time. But all the different treatment modalities, we'll go through these and just sort of touch on them. Chemotherapy is, a lot of people when they think, I've got cancer, I'm going to get chemotherapy. Not always. We have a lot of different treatment options now. But the drugs that have been around forever, especially in lung cancer, cisplatin, etoposide, paclitaxel. And a lot of people believe, oh, I'm going to get, chemo, I'm going to be sick, I'm throwing up. Oh, no. Our drugs have come a long way as far as our medicines to try to help prevent those side effects. Surgery. These earlier cancers, the earlier your cancer is caught or the earlier stage. A lot of people I always tell my patients, it's unfortunate that you have lung cancer, but it was fortunate you caught it early. Or a lot of these are found incidentally, though. So these are the ones where you can have surgical resection and you don't have to have treatment. And move on to targeted therapies. As science has evolved, we've gotten a lot better at finding a lot of these mutations that drive your cancer. So we have new treatments that target those drivers and shut off and kill the cancer that way. We'll talk about that a little bit more in a minute. And then, of course, immunotherapy. 20 years ago, the first immunotherapies were done. Gentleman that got a Nobel Peace Prize in MD Anderson on those early clinical trials in melanoma. But we have a lot of immunotherapy options, and a couple that are more prominent in lung cancer. And we'll talk about how those work. And then, of course, radiation therapy. A lot of different ways that we can use radiation in lung cancer, and we'll talk about that too a little bit more. Also, a lot of the nomenclature you may hear a lot of people in the medical world talk about neoadjuvant treatment. That means before surgery. So a lot of times the purpose of that is to shrink down the cancer, make it smaller. So surgery is a little bit easier. And it's not as it's invasive, but it just makes the surgery easier for the surgeon and for you. Adjuvant is after surgery, and that's adjuvant chemotherapy or adjuvant radiation. How I remember that, adjuvant is after. It's just a little way that I can remember that myself. Next slide, please. So, talk a little bit more about the immunotherapy and targeted therapy. So, the way I like to explain immunotherapy is basically it manipulates your own immune system to find and attack and kill the cancer cells. Targeted therapy, that's where we find these mutations that are found that is responsible for your cancer. And those drugs work by targeting those mutations to shut those off and kill cancer that way. So for targeted therapy, of course, you have to have those mutations. That's where you hear the EGFR, the KRAS, ALK. Those are targeted mutations. Immunotherapy, you have to have certain characteristics of your cancer for you to receive immunotherapy. You may hear people turn around the terms PDL, TMB. Those are things that we as providers look at to see if you're a candidate for immunotherapy. So the things with immunotherapy you have to watch for, if you think about it, we're manipulating your own immune system to fight and kill those cancer cells. So what you worry about, which thankfully they don't happen very often at all, is where not only does your immune system think that the cancer cells are foreign, but your own organs are. So that's why you have to watch for, cough or dry, hacky cough. That could be your lungs are inflamed, which is really hard sometimes when you have lung cancer because you already have those. You watch for, your immune system attacking your colon, diarrhea that you can't control, looking for yellowing of the eyes, jaundice, which could be your liver's inflamed. We watch your blood sugars just to make sure that your pancreas is working well. I've known of one case of a patient that had, as we say, immune-mediated diabetes, got steroids is how we stopped those side effects, and that cleared up, and it was cured. So a lot of people, immunotherapy is wonderful. You don't see these terrible side effects, very rare, but they are treatable, and so that's why I always tell people if you're on immunotherapy and you're noticing these problems, you got to let us know because we have to give you steroids to reverse them. Targeted therapy, I think it's across the board. Most of our targeted therapies, one of the biggest side effects a lot is fatigue. A lot of fatigue. A lot of times they have a lot of GI issues too. Those are almost across the board. You can see those with the targeted therapies. Next slide. Talking about our targeted therapies. So you may hear your providers say NGS testing. That's next generation sequencing testing. And you can do these tests by two ways. You can look at the actual sample or biopsy they get from the lung, or you can do it with blood draws. So if you have cancer and it's worsening, usually your doctor will order these tests anytime your cancer gets worse. And we're looking for these different mutations that we can give you as a treatment option. So as you'll see toward the bottom, the most common are EGFR and then KRAS. KRAS is in the yellow and EGFR is blue. And those are our most common mutations that you do see. Then that's followed by ALK, BRAF, MET, HER2, ROS, and my eyes are, okay, we have RET, NTRK, and FGFR, which those aren't very common. I remember when we had our very first ALK patient that got started on treatment. I was around before all these mutations were around, so it's so exciting to see so many different and new, more innovative, less toxic treatments for patients. But if any time that you're having, your cancer looks like it's getting worse and they're looking at other treatments, that's a question you may want to ask. Are you doing the testing to make sure that we're looking at my mutations? Next slide. So these are just some very sophisticated pictures to show you how immunotherapy works. One way is it sort of puts the brakes on your immune system. The other one, it takes the brakes away. Just know that how it works is it manipulates your own immune system to target, attack, and kill the cancer cells. Next slide. So I'm going to talk a little bit more about small cell lung cancer. Kim covered non-small. If there's some people in the room, you may have had your mom or your grandma, they used to call it oat cell. Has anybody ever heard the term of oat cell, or am I been around way too long? Yes, I got some people in the back. But when I started 30-something years ago, that was what we called it, was oat cell cancer. And like I said, this is the small cell lung cancers. Kim touched on this a bit. It covers about 10 to 15% of all lung cancer diagnosis. So it's very aggressive. This can be where you felt great 2 months ago, and then like 2 months later, you can't walk up the stairs, you can't breathe. These come on very quickly, and the symptoms come on very quickly. If you think about it, they're rapidly growing cancers, and these cancers, upfront treatment is usually chemotherapy. And so chemotherapy targets and kills rapidly dividing cells. This is a rapidly growing cancer. So that's why, if it's you or your loved one, once you start treatment, you start feeling better a lot quicker. But it is very aggressive, and it has a higher tendency to recur. Next slide, please. Like I said, it's about 15% of all the lung cancers, like I said, the most aggressive. And as you see, 98% of people that are diagnosed with small cell lung cancer are smokers. Like I said, this is a fast-growing cancer, so it moves a lot quicker. Number one place it likes to go is the brain. So some people may not even have it, or your loved one, your grandma, your aunt, your sister has a seizure. They don't know why. They get a workup done. It's either you could have a brain met, or as you see down here, it's something called paraneoplastic syndrome. This is a lot of the myriad of the symptoms and problems that come along with it, and one of them is a low sodium level. So if that sodium level gets too low, you can have a seizure. And so unfortunately, some people are diagnosed by some of the symptoms that they present with. Next slide. So as you see, we have two different pictures. On the, which is it on your right, is limited. So this is where it's confined just to that one area in the lung, and you see you could have that one little lymph node on that side. That is limited stage. If you look at the other picture, that's where you have extensive. So we have limited or extensive. Limited, we can still try to treat for cure, but it is very aggressive. The extensive, basically, it'll go with our Western theme. If you think about it, it's, the horse is out of the barn. It's already spread. So that's a lot of times why surgery is not an option for you if it's already spread, because the horse is already out of the barn. So our treatment is try to shrink down that cancer, keep it under control, and extend out a life as long as we can. Next slide. So if we're looking again at the treatments, the limited is, remember, it's confined to that one lung, maybe a lymph node. So if you look at the options, If you have no lymph node involvement, then you look at chemotherapy and surgical resection or lobectomy. That's just removing that portion of the lung where it's affected. But if you do have that lymph node, you usually put in some radiation with that. And the reason you give chemo and radiation together, chemotherapy makes radiation do its job better. And so we give it together to try to make that radiation work better. So if you have limited stage and you'll have a MRI of your head done just to make sure that cancer hasn't spread to the brain. But when you're done with your chemotherapy, then we look at doing what we call PCI or prophylactic cranial irradiation. And basically you get a low dose of radiation therapy to your whole brain to try to prevent the cancer from going to your brain. On the other side, if you have extensive, that means it's spread either to the other lung or to the other organs. And so with extensive stage, we didn't have a lot of options 10 years ago, but now with the involvement of immunotherapy, you get a combined treatment with chemotherapy and then immunotherapy, and we do what we call maintenance therapy once you're done with the chemotherapy portion, and you come in and get immunotherapy. You don't lose your hair, you have maybe a little bit of fatigue after the infusion for a few days, but people are able to live their life and feel much better. Of course, other things that we look for, like I talk about someone that came in with a seizure, if they had a brain met, you'd want to treat that brain metastasis, or what we say brain met first, get that under control, and then you start your systemic therapy, is what we say, chemotherapy. And usually do treat the disease before, if you're not symptomatic, before whole brain radiation. Next slide. So a little bit more about the PCI, or prophylactic cranial radiation. We want to make sure that you're responding, your cancer's responding, that's shrinking down. We don't see any signs of cancer in your brain, and that when we say good performance status, we talk about are you able to care for yourself, go about your daily, activities, and no major neurocognitive issues. A lot of times you have people with Alzheimer's or advanced dementia. They're not the best candidates for PCI. I've talked about there's some guidelines that go with it, but the bottom line is it's usually if you have treatment for cure or early stage, a lot of times you can opt to do PCI. There's been a lot of data and information. A lot of times you give people low doses of some of the Alzheimer's medicines to try to help with your memory, which is pretty much a standard now. Next slide. So early detection, and Kim may want to chime in some of these. So we do have a low dose CT scans for screenings. We actually do screenings at my facility once a year for first responders, but anybody off the street can walk in and pay $75 and get a CT scan. There's also a lot more data driving now. We're watching for cells that are circulating in your body after treatment to try to have a measure, watching for early recurrence of your disease. And of course now we have AI and machine learning that you're having a lot of AI overlaid with some of your diagnostic imaging that can detect it a little bit earlier. Next slide. That's the wrong part, Kim. Sit on the side. So as we're talking about lung cancer treatments, things that are common and they're a little bit different, like if you have an early lung cancer now, instead of sometimes having chemotherapy, you can be offered a lot more of these targeted therapies. Some of you may be on drugs like Tagresso. A lot of those, we're seeing those given a lot earlier instead of chemotherapy. Immunotherapy, there's been some data and studies that show that you do some immunotherapy with chemotherapy up front, shrinks down that tumor, then you can have surgery. I think if there's any of our surgeons in the room, they're a little bit not bought into that all the way. But those are some great data with that. Some advances, of course, is our targeted therapies, our immunotherapy. And of course, there's so many clinical trials, not even in the US, but all across the world on lung cancers. that are very, very needed. Next slide. So if you see, we've made a lot of advances in cancer. So in the medical world, when you see these lines separate, that's always a good thing. From 1970 to 2010, our science has gotten better data, better treatment, and better treatment outcomes. Conversations I have with patients 15 years ago, 20 years ago, especially if you have stage 4 cancer, is a very different conversation than what I had 20, 30 years ago, which is wonderful. Kim, Kim knows some more new innovative technologies that are being used, if you want to touch on those.
So I, like you said, I started a lung cancer program about 7 years ago, and just from the 7 years when we built the program, ours is all about early detection. So even those that have lung nodules very early on with those risk factors, we can add any blood tests to them at early stages to see if this is a cancer. And so we do have a sputum test that we can offer. So if you have a 4, 5, 6 millimeter nodule, instead of just watchful waiting, we can add this sputum test, and there's also a blood test that let us know if there's some circulating autoantibodies that show that it's a higher risk for cancer, or does it decrease your risk for cancer and show some more inflammatory markers, which really gives patients a little peace of mind early on without a cancer diagnosis. So that's one thing we can do with lung nodules, early detection. As she said, the CT machines, and one of the newest things, it's crazy what AI can do, but our radiology department has an AI system that can look at the size and history of a nodule and let you know if it's higher risk for cancer, when before, radiology would just read a slide. We would get, as a provider, we'd look at their risk factors, but now we can even take that one step further, and they can actually see by the imaging and shape and size if that's a higher risk. And then we add our technology, so it really gives a patient early detection versus going straight to biopsy. So, anything else? I think that's it. If there's questions, we have about 6 minutes left, so we will go ahead and get started with some questions.
Good afternoon, everyone. Let's see. First, I want to thank Kim and Shandy for their great presentation. It really resonated to me that you were speaking in layman's terms, because that's really, I understood a lot of the things you said. My name is Mickey Harris. I recently retired after 50 years in construction, and back in last September, I was diagnosed with cancer of an unknown primary. And after my anthology report came back with a RET mutant gene, which is apparently very rare, I'm being treated at Memorial Sloan Kettering in Manhattan with targeted therapy, which has been working great. Okay, well, let's get to the Q&A. Okay, let's give me a second here. Okay, our first question. Some people have neuroendocrine tumors in their lung. Although we don't have a slide, can you give a short explanation of what it is, how it differs from non-cell to small cell?
Yeah, so neuroendocrine tumors, you can have, they can be found anywhere. Actually, one of my best friends that's going to be joining us later, she had a neuroendocrine cancer tumor of her lung. These are super slow growing cancers. Like, we're talking years, 5 to 10 years. Most of these are found incidentally. She was having back pain. I'll just use her as an example because she's easy and I know her. She had a super small little nodule that was found by her chiropractor because she was having back pain. And she had a great chiropractor. He said, you need to look this looked at. And she mentioned it to me and she was blowing it off. I'm like, no, you have to get this looked at. She was seeing more of an integrative medicine physician, doctor, that was sort of telling her she didn't need a CAT scan. And I just do what best friends do and said, that's BS. You've got to have a CAT scan. So she had a friend that she saw that was also, she saw for pain management for her back, and he ordered the CT scan, and he called her, and he's like, I think this looks malignant. And it just happens to be that I called Kim. Kim got her in, got her worked up. They knew right away that it looked like it was a neuroendocrine tumor. And so she was in who I would go to in a heartbeat for surgery. One of our doctors in Fort Worth, the surgeon, he did her surgery, laparoscopic robotic, and she was out of the hospital in 2 to 3 days. So those are very different. They're different from where they arise from, and they're super slow growing, and the lungs are usually called coincidental.
Yeah. And the other thing that you'll see in a pathology report is neuroendocrine or carcinoid.
Yeah.
So there's a typical and atypical.
Yes.
They're not very common, but I tell my patients if I had to have a diagnosis, please give me a carcinoid in the right middle lobe,
Yes.
because that's the smallest lobe to take out. And one of the things our presentation didn't talk much about, but is surgery, because if a patient has early lung cancer, the research is shifting, but previously, to take out a cancer, it's recommended to take out a lobe. The patients think that we're going to just go take that spot and remove it. There is new data out there that's showing we can do what we call a segmentectomy, meaning taking a segment of the lung out versus the whole lobe. But when we talk about lobes, you have a left, upper, and lower. That's like pretty big percent of your breathing. And lung cancer early, we would take out the whole upper, if that's where it's at, or the whole lower. So you have to learn how to breathe different after that. But the new data, especially carcinoids, we do a lot more segmentectomies, taking out a segment.
And if I can interrupt, the reason you can do that is because they're so slow growing. You could never do that with like a non-small cell.
Yeah, or small cell. Yeah. And surgery is usually just quick surgery. You're in the hospital 2 days. You're up walking right after your surgery. So if you do it full robotically, and her friend was exact example, I've had people go home in 24 hours, but you're in the hospital, it's removed, you're up eating dinner, walking around. Next day, chest tube comes out, and then you go home. And we've done 250 plus with my program in 7 years.
Her recovery was shorter than my recovery from my hysterectomy. Let's just put it that way.
Okay, are lung nodes different from lymph nodes?
Yes, this is Kim's bread and butter.
Yes, so lung nodules are very different than lymph nodes. Lymph nodes, we have head to ankles. They are our protective mechanism to fight any infection. Those lymph nodes can enlarge if there's inflammation, infection. A nodule specifically can be inflammatory and infection, but it's the location of them. I do have occasionally where a radiologist will read a scan, and if it's in between the lung or the fissures where lymph nodes reside, a radiologist can't even tell. They'll say, 3 millimeter nodule, left fissure, could be a lymph node, possibly a nodule, but they are different, and it's by the location where they're located. If they are where a lymph node would be, and it's the size of a lymph node, they can't really distinguish, but a lymph node's not going to be out in the peripheral lung. They're in the center, and there's a diagram where you can see exactly where our lymphatic chain is. So they are very different.
And nodule is just a fancy term for a
spot
or a
in
growth.
the lung. Yeah.
If you say you have a spot in your lung, that's a growth. Those are all interchangeable nomenclature.
Okay, final question. Do we know what causes mutations?
There's a lot of different things can drive mutations. It could be genetics, that you're born with it. It can be some of your exposures, but sometimes it's just that the cancer is outsmarting us in what we treat, and you can develop these mutations. You can not have a mutation when you were diagnosed, and then we end up doing more of that, we said NGS testing, and then we can find new mutations. They're drivers for the cancer, if you think about it that way. And I think I saw a gentleman have his hand raised.
He couldn't hear me.
Okay. I think you had a question. I don't know if you used the thing. Yes.
Technology's not working.
Okay.
One of you ladies said that your hospital offers low-dose CT scan for about $70. Is that?
Yeah, my Cancer Institute where I work, we have all across the Metroplex. If you're here in Texas, it's free for first responders. your firefighters, EMTs, but anybody can go in and have a low-dose screening CT for $50?
It's 50.
Yeah, Kim knows.
Yeah, it's 50. We actually use
Yeah,
her
that's-
program to send our patients, because I'm hospital-based, and it's a lot more than 50 in a hospital, so we send them to her.
Well, I'm a Texan,
Okay.
and I've never seen that advertised.
Yes. I
So-
could give you the information afterwards. Or
Pardon
I
me?
can tell everybody right now, it's the Center for Cancer and Blood Disorders. We have offices from Mineral Wells all the way up to McKinney, everything in between. You can, if you are Facebooker, you can join our page, and we put it on our page when we're going to have those. They're always in the fall, before Thanksgiving.
One would think that given the danger of our disease, which is late finds, that something like a low-dose CT scan at an affordable cost would be broadly advertised.
So a lot of times your insurance can pay for them, but you have to meet certain criteria.
But at that level, most people can afford it.
Right.
So
Yes.
insurance would be irrelevant.
Yes.
The benefit of an early find in this disease is, well, it's the key to survival.
Yeah.
So I would encourage you to broadly advertise the availability
Yeah.
Sure.
and the price of that kind of a scan.
Yeah, and
Yeah.
that we feel that's a service that's needed for our population. So, yeah.
Yep.
But yeah, the
And-
Center for
and-
Cancer and Blood Disorders.
And I will say that's my biggest, thing with lung cancer. Colon cancer, we get screenings at 45, breast cancers at 40, PSA starts screening at 50. All of those cancers, we have stage shifted significantly due to early detection. And I hate to say it, but it's insurance. Why can't everybody get a low-dose CT at 50? I mean, it's going to save everybody money on the insurance game. It's going to extend lives of patients. And I hope, I still have about 20 years in my career, that it doesn't have to be someone that's 50 to 77, 20-pack more smoker, no CT within the last 12 months. The criteria to qualify for a lung screen versus a colonoscopy, mammogram, PSA, it's completely different. If you quit smoking 16 years ago versus 15, you're excluded. Your risk factors don't decrease, but because of insurance, you're completely excluded. So I'm hopeful in my career that I'll see insurances saying, everybody at 50, regardless of your smoking history, you can get a low-dose CT. But we're not there yet.
I think we're done, but Kim and I, we'll be in the back if you have additional questions. We don't mind at all.
All right. Thank you, Kim and Shandy,
Thank you.
for sharing your expertise with us. And thanks everyone in the audience and on the live stream for your thoughtful questions. Thanks again.